Video, please.
Yes, sir. We can hear you, sir.
Yeah, I can just, now it's good. Yes, okay. Hi, good evening, everyone, and welcome the Bengal chapter for the Young Guns webinar. I can tell you this young gun thing is hitting off so well. So many young people lining up to present their work. It's an amazing feeling to see so much of good work coming from all over the country. And this time we have the Bengal team, which has come actually taken in fantastic cases from all the young people, which they will present. And believe me, these are proper worked up cases. So what you see is not only ultrasound images, which are world class, but they've actually worked it up right up to the final conclusion. And that is the most satisfying feeling for any sonologist, radiologist, or fetal medicine specialist. So I welcome our president of Bengal chapter, Dr. Sita, to take over the proceedings from here. Over to you, Dr. Sita Ramurtipal.
Thank
Wish you
you.
all the best.
Thank you. Thank you. Thank you, Dr. Mohit, for giving us this opportunity. And of course, Khurana sir and the entire SFM team for giving this Bengal chapter or the Young Guns webinar where all the young Turks are ready to present.
Yeah.
Basically, this concept we were thinking for a long time, and 13th of March was World Kidney Day. And, we sort of thought we will do something on that aspect. So considering that the theme for this, in fact, it was detecting renal diseases early, early detection of renal diseases. So it's the same as for adults of our fetuses. I think the concept and the idea remains the same that, we go along detecting any kidney renal issues in the fetus, how to counsel them, how to take it forward, whether it is compatible or incompatible with life. So we have our young guns ready with all the different cases which we might encounter, common, not so uncommon, rare ones. And so without wasting time, we would like to go on to the scientific session. And thank you once again to all our young presenters and to, of course, Dr. Alok Ashne for mentoring and to Khurshid as well for coordinating this so well. Thank you, Team SFM, and thank you, Dr. Mohit, once again. Over to you. Thank you. Rashid, you're there? You can just start off with them.
Yes, Sita, I'm there. So shall we start the proceedings?
Yeah. Your voice is breaking
Yeah,
up.
voice is cracking, Kushit. Is there any other parallel session going on?
No, sir.
Uh,
I'll just move to other place. I'll see. Maybe network connectivity.
no, it's not the network. There's a
Am I audible now, sir?
Yeah, you're audible, but there is a bit of disturbance.
Disturbance. Okay. I'll do one thing. I'll just rejoin once.
Better now.
you're
It's much
better now.
better.
You're better.
Much better.
Better?
Yeah.
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 Okay. Okay. Actually, before this, I was not able to hear. Till now, where were you? Actually, just I wanted to understand.
No, we've lost you again. I think you can just.
I'll just rejoin once.
I think we'll start off with the
Yeah,
presentation. Yeah.
Meanwhile, you
So
can just disconnect and connect back
come
again,
again.
Kushit.
I will
Yeah.
call the first speaker.
Yeah.
Yeah. So we start off with our first session of speakers. We have Dr. Vinayak Das, who's going to be presenting on ecogenic kidneys. Vinayak, all yours, please.
Thank you, ma'am. Thank you, everyone. Thank you for this wonderful opportunity.
To share your screen, Vinayak. A brief
Yes.
introduction about Vinayak. Vinayak is a practicing fetal medicine consultant in Siliguri, and so we go on to full screen and to the first slide. Over to you, Vinayak. Thank
Good
you.
evening, everyone. case I'm going to present today is about fetal echogenic kidneys. I'm Dr. Vinayak Das. I'm a consultant maternal fetal medicine specialist, and I am practicing at New Ramakrishna Seva Sadan in Siliguri. So the case is of a 32 years female, gravida 2 parity 1, non-consanguineous couple, low risk in combined first trimester screening. There is no family history of renal disease, and she came to us at 19 weeks, 5 days period of gestation. The gestation age was confirmed as per the 12-week scan, and the gestation was finalized as per LNP. So we found that there was bilateral increased echogenicity in both kidneys. The kidney size in the right side was anterior-posterior 20 millimeter, and left side it was 19 millimeter. The amniotic fluid levels were normal, bladder appeared normal, and fetal growth was also normal. So as you can see here, the growth was appropriate as per gestational age. The aneuploidy risk in combined FT was low risk, but the free beta SAG was slightly on the lower side with 0.26 mom. So this is before I go into our case, so this is a normal kidney at 22 weeks. And as you can see, the echogenicity of the kidney is less than liver or spleen. So the diagnostic criteria for echogenic kidneys is that the kidney should be more echoic or brighter than the liver or spleen after 17 weeks of gestation. And the loss of corticomedullary differentiation is the best surrogate for hyperechoic kidneys. And you can see that echoic kidneys appear hyperechoic in both sides, and there's a loss of corticomedullary differentiation. So we asked the patient for additional invasive testing, and they opted for fetal whole exome sequencing. And in the sequencing, we found that there was a ZMYM2 mutation, which is a neurodevelopment and craniofacial syndrome with variable renal and cardiac abnormalities are present, which is autosomal dominant. But the report had come as a variation of uncertain significance. So ZMYM2 gene is a nuclear zinc finger protein that localizes to the nucleus, especially to PML body, and it forms part of the transcriptional complex acting as a co-repressor by interacting with different nuclear receptors. And the role of ZMYM2 in kidney and ureter development is largely unknown. So the patient initially wanted to go for termination of pregnancy. They went to PG hospital. The PG hospital denied termination of pregnancy on the basis that just having this mutation, which was a variation of uncertain significance, does not justify termination of pregnancy because it's not lethal abnormality. And so the parents decided to continue. Once they decided to continue, they took multiple genetic consultants' opinion, and then they went for the exome sequencing of both parents. And interestingly, on both parents' exome sequencing, we found that the father had also a same mutation, ZMYM2, and the innate were autosomal dominant. So this was the 30 weeks growth scan. As you can see, there is still loss of corticomedullary differentiation, and the kidneys appeared hyperechoic. The growth was normal. The abdominal circumference was 45th centile, and the estimated fetal weight was 50 centile. And the Doppler study of umbilical and middle cerebral arteries had normal flow. Now, the postnatal follow-up, till delivery, the kidneys appeared hyperechoic. Initially, after delivery, the urea or creatinine was raised, but it later normalized. The latest follow-up that we have was at 6 months of age. The baby is doing fine with normal renal function test. So coming to the discussion, fetal renal development starts at week 4 or 5 weeks of gestation, and mainly at the 14th and 16th weeks of gestation, kidneys begin contributing significantly to the amniotic fluid volume. And so it's the earliest point where we can make a likely diagnosis of hyperechoic kidneys. Week 20 plus, there's rapidly ongoing nephrogenesis, and it's a better differentiation of renal infrastructure and cortex for medulla. So the diagnosis of hyperechoic kidneys should be done by 20 weeks of gestation. So hyperechoic kidneys, there's always a perception that the diagnosis is uncertain, course is uncertain, and the prognosis, we cannot really say about the prognosis of the fetus to the parents. So is this a perception or is there a reality? So we must understand that hyperechoic kidneys is per se not a diagnosis. Hyperechoic kidneys is a sign, and it's also a diagnosis of exclusion. That means we must look into all the other systems to rule out other genetic syndromes before giving the word isolated hyperechoic kidneys. So as you can see, hyperechoic kidneys is a sign, and it could be associated with trisomy 9 trisomy 13. It could be associated with monogenic disease like Beckman-Whitman syndrome, Bardet syndrome, and it could be associated with viral infection. It could be associated with obstetric uropathy. It could be associated with renal thrombosis, and it could be also normal variant. So the renal outcome of fetuses with isolated hyperic kidneys is generally good at 70% of cases having normal renal function postpartum. But again, we should rule out multi-system abnormalities, and also we should try to go for genetic testing to give the diagnosis as isolated. So on invasive testing, what should we go for? So if we have found multiple abnormalities and we only go for KD tapping, the yield is around 30%. But if we add high resolution microarray, chromosomal microarray, the yield increases by 4 to 6%. Now, if we can go to whole exome sequencing, ideally try sequencing, or at least the fetal whole exome sequencing, the yield increases up to 9 to 12%. Also, we can, in kidney abnormalities, we can go for targeted testing. Like if there's severe pelvic ectasis, we can look for trisomy 21 or 22q deletion, 11 deletion. If there's horseshoe kidney, we have to rule out trisomy 18 and Turner syndrome. And in echogenic kidneys, trisomy 13 and deletion 17q12. So I'm not going into detail to all the genetic syndromes. What I want to emphasize here is that hyperechoic kidneys in isolation, before saying the word in isolation, we must be absolutely sure it's actually in isolated cases. And to do that, we need to go thoroughly for all the genetics, for all the systems. As you can see in this list, that if, specifically the ones I've highlighted, those are associated with ciliopathies. So hyperechoic kidneys with post-axial polydactyly or genital abnormality could be Bardet-Biedl syndrome. Hyperechoic kidneys with or renal abnormalities with skeletal dysplasia could be June's disease. Renal abnormalities, hyperechoic kidneys with cerebral abnormalities with polydactyly could be Joubert syndrome. And renal abnormalities, hyperechoic kidneys with cephalocele or polydactyly could be Meckel-Gruber syndrome. Other than that, if there is increased growth like hemihypertrophy with abdominal wall abnormalities, it could be also Beckman-Whitman syndrome. So a lot of genetic syndromes associated with hyperechoic kidneys, and we must look into all the systems, specifically CNS systems, skeletal syndromes, and we also must rule out polydactyly, because polydactyly is a very important part of diagnosis of syndromic association of hyperechoic kidneys. So these are the various signs which could point towards ciliopathy in the fetuses with hyperechoic kidneys, like short ribs, limb abnormalities, posterior foracial abnormalities like molar tooth sign, polydactyly, echogenic or polycystic kidneys, or situs abnormalities. So how do we go forward prognosticating or counseling the patient with hyperechoic kidneys? So hyperechoic kidneys with normal anatomy, with normal liquor and normal genetic test, then we can safely say that the 70% of fetuses with hyperechoic kidneys with these findings will have a normal postpartum renal function test, and most likely will have a normal postpartum life. But if there's hyperechoic kidneys with abnormal liquor volume, with normal anatomy, or normal or abnormal genetic report, then we must pause and take a consultation with the genetic consultant and prognosticate that the uncertain prognosis of the future fetus post-delivery in these cases. And if we find that there's hyperechoic kidneys with abnormal liquor, with associated other abnormalities like we have seen in the other previous slides, like polydactyly or the skeletal dysplasia, and also if there's associated abnormal genetic report, definitely the prognosis of the baby is poor, and we must counsel the parents accordingly. So this is basically an algorithm when you find a bilateral hyperechoic kidneys in the anomaly scan or any scan. And I will not go into each of the syndromes. Just what I want to emphasize here is that as soon as we find a hyperechoic kidneys, we must rule out any other associated abnormalities, and that includes first we must rule out there's no bladder outflow obstruction. We must go to we must see the KUB system, kidney ureter bladder system, and see if there's associated any extrarenal finding. And if there's any CNS findings, if there's any skeletal finding, including if there's any short bones, any polydactyly. And after ruling out all this, then only we can say the word isolated. So if there is a bilateral hyperechoic kidneys with no additional external finding and no liquor abnormalities, no cardiac abnormalities, and we do a parental scan, and the parents also don't have any kidney cyst, then we can reevaluate of 2 weeks, and we can give the diagnosis with normal genetic reports. We can give the diagnosis for isolated hyperechoic kidneys. But to give the report for hyperechoic kidneys, we must first take a detailed anatomy scan and rule out any other small markers that we can associate with other syndromes like Bardet-Biedl syndrome, Beckman-Widman syndrome, like any anti-abdomen wall syndrome, anti-abdomen wall abnormalities or macroglossia. And then only we can give the report as isolated hyperechoic kidneys. Thank you, ma'am.
Thank you, Vinayak, for this wonderful overview on the topic of echogenic kidney. Now you have opened Pandora's box, and there are more questions and answers on this topic. Am I audible?
Yes, sir. Yes, sir. Thank you, sir.
Very well. Yeah.
So you have taken us right through the normal variant, lot of genetic syndromes, how to join the dots and reach to a reasonable differential diagnosis with case presentations and all. At this point, I would like to say that we can go for the next presentation, and discussions and question answers can be done at the end of when all the speakers have completed. If that is okay, Dr. Mohit Shah and Sita, if that is okay with all of us.
Yeah, I think so. Yeah, I think
Yeah,
that
yeah,
everyone
yeah,
present.
yeah.
Okay, so let us just maintain the flow of event. And
Right.
with this, we come to the conclusion of the echogenic kidney, and we'll start with the next topic of urinary tract dilatation. So Dr. Shikha Marwa will be presenting on urinary tract dilatation.
Good
Shikha,
eve-
are you there?
Yes, sir. Good evening,
Yeah, please.
everyone.
So Dr. Shikha has just joined us in our clinic of Fitomat, and she has done her 2 years of fellowship in Fernandez Hospital, Hyderabad, her fellowship in fetal medicine. And now she is doing a wonderful job in fetal medicine, very passionate about her imaging and her reporting. So let us hear from her about the urinary tract dilatation. Please go ahead. Floor is all yours.
Thank you so much, sir. Thank you for this wonderful opportunity today. So let us move to the next topic, that is urinary tract dilation. So 22-year-old Mrs. X, gravida 1, was referred to us at 33 weeks in view of bilateral fetal renal pelvic fullness. It was a non-consanguineous couple with no significant family history or personal history. For her, aneuploidy screening was not done. Ultrasound done at our center at 33 plus 2 weeks showed single live fetus, cephalic presentation with estimated fetal weight of 31 centile and adequate liquor. We noted bilateral renal pelvic dilation, left being 25 millimeter and right being 22 millimeter. The central and peripheral calyceal system was dilated on both sides. Bilateral ureter appeared prominent and urinary bladder appeared thickened. However, there was no extra renal abnormalities noted. So, since it was bilateral gross dilation of the collecting system with prominent ureter, we gave a diagnosis of query luto, that is the lower urinary tract obstruction. She did not have any further scans with us. We followed this pregnancy through. She had a cesarean section done at 38 weeks and birthed a boy baby of 2.7 kg. Baby had a micturating cystourethrogram which showed bilateral vesico-ureteric reflux. However, there was no posterior urethral valve noted. DMSA renal scan showed no cortical scar. DTPA was done for her, which showed mild impaired cortical function. The most recent update that we have is baby is around 15 to 16 months now. At 15 months, baby had vesicostomy, which was done to decompress the bladder, and they're suspecting probably it to be a detrusal function abnormality. So with this background, let us move to the discussion of urinary tract dilation. Urinary tract dilation, that is abnormal dilation of the urinary collection system. It is the most common finding on prenatal ultrasound. It is seen in 1 to 2% of pregnancies and comprises some 10% of all prenatal structural abnormalities. However, remember that UTD is a sign or a finding in ultrasound and not a diagnosis. This dilation may either be transient or physiological, as seen in 70 to 80% of cases, or it may represent a significant uropathy of variable etiology and presentation. In many, this etiology is not determined before birth and it is diagnosed postnatally. Now, there was no uniformity in defining and grading urinary tract dilation because of many grading systems like descriptive, quantitative, and semi-quantitative. So, correlation between prenatal and postnatal ultrasound findings and the ultimate urological diagnosis was problematic. To overcome this, 8 societies who had special interest in the diagnosis and management of fetuses and children with UT dilation, they came together to develop a single unified grading system, which can be applied both antenatally and postnatally with a consistent terminology so as to make communication between different specialties easy. Now, different terms like hydronephrosis, pylectasis, pelvictasis, uronephrosis, pelvic fullness, UT fullness or prominence, they all create confusion because each of them has a different implied meaning. So the consensus panel has recommended to avoid using these terms and rather consistent usage of a term, urinary tract dilation. Now, what is this classification? Urinary tract dilation classification is based on 6 ultrasound parameters, that being measurement of the anteroposterior renal pelvic diameter, which I will be talking further on. Calyceal dilation, both central and peripheral, has to be noted. Subjective assessment of renal parenchymal thickness. Then evaluate the renal parenchymal appearance for echogenicity, corticomedullary differentiation, or any cortical cysts. Ureter, if dilated, is abnormal. Also look for bladder abnormalities like thickened bladder wall or uretrocele. Anteroposterior renal pelvic diameter is measured in axial plane with spine at 12 o'clock position. The caliper is placed at interior margin of renal parenchyma and we measured across the widest portion of fluid containing renal pelvis. This is just a gist of all the ultrasound parameters that I've discussed before. Note that if in case of UTD, we should always measure the kidney length and then compare it with the gestational age specific nomograms. Now, for antenatal evaluation, now the threshold value for diagnosis of urinary tract dilation is stratified based on gestational age at presentation. Normally, the measurement of this pelvis, it is less than 4 millimeter before 28 weeks and less than 7 millimeter at and beyond 28 weeks. And also normally there is no calyceal dilation. The renal parenchyma has normal thickness and appearance. Ureter is not dilated and bladder is normal. However, if the renal pelvic diameter measures between 4 to less than 7 millimeter before 28 weeks and between 7 to less than 10 millimeter 28 weeks and beyond, with or without central calyceal dilation, we grade it as UTD A1, which is low risk. Anything above this goes to UTD A2 and A3, which is considered high risk. Also, if there is peripheral calyceal dilation, ureteral dilation, renal parenchymal abnormality, bladder abnormality, or unexplained oligohydramnios. Now, the concept behind clubbing A2 and A3 together is because antenatally differentiating between central and peripheral calyceal dilation may not be always possible. So both of them are clubbed together in the high risk category. Once we have UTD, it may resolve, it may remain stable, or it may progress. Now, the likelihood of resolution is related to what is the severity of the pelvic diameter that we have at the time of diagnosis. It is said that if it measures between 4 to 8 millimeters in second trimester, resolution is seen in 80% of cases. However, if it measures more than 9 millimeters, resolution will be seen in less than 15% of cases. Now, coming to risk-based management. If we have UTD-A1 in hand, we should plan an additional ultrasound at 32 weeks. If at 32 weeks, the dilation has resolved with other parameters being normal, then no further prenatal or postnatal follow-up is necessary. If not, then after birth, an ultrasound has to be done for the baby after 48 hours of birth to 1 month, and hence after and 6 months later. If we have UTD A2 and A3, we should plan for an ultrasound 4 to 6 weeks from the initial time of diagnosis, thereafter depending on clinician's discretion. And it is always good to have a consultation with pediatric urologist or nephrologist so parents can understand the postnatal outcome and management. Again, after birth, an ultrasound is planned after 48 hours of birth and after that according to the situation. Postnatally, the same classification transcribes to P1, P2, and P3. Now, timing of the first postnatal ultrasound is very important and it has to be planned 48 hours or later after birth, not before, because we might underestimate the degree of hydronephrosis, partly because of dehydration. Now, with this system in hand, we have a uniform definition of urinary tract dilation with very clearly defined ultrasound measurements. It is applicable for both prenatal and postnatal life, and it ensures a correct follow-up postnatally for all the babies who had an antenatal diagnosis. However, remember that this classification is applied only to isolated urinary tract dilation and not to be applied to anomalous kidneys. Now, with UTD in hand, our aim should not to be give it just at UTD A1 or A2. We should try to delineate what is the level of obstruction and what might be the underlying etiology, if it is upper or if it is lower. Etiology of this urinary tract dilation can either be physiological or it can be because of pelvic-ureteric junction obstruction. It can be obstruction by an overriding vessel. It can be a uretero-vesical junction obstruction, megaureter. There can be vesico-ureteral reflex causing it, a duplex kidney, a ureterocele. Or there might be posterior urethral valve, urethral atresia, urethral stenosis. It is also seen in prune belly syndrome, cloacal dystrophy, and megacystis microcolon syndrome. How do we come to a possible etiology? When we see hydronephrosis, look at the ureter. If it is dilated or not? If it is not, it may be an obstructive uropathy, like maybe a pelvic-ureteric junction obstruction. If yes, then go and look at the bladder. If the bladder is not dilated, it can be unilateral vesico-ureteral reflux, or it can be a uretero-vesical junction obstruction. If the bladder dilation is moderate, it may be bilateral VUR, and if it is severe, it is probably posterior urethral valve or an atresia. Coming to each of the etiology in short, pelvic-ureteric junction obstruction, there is variable degree of pelvic calyceal dilation without ureteral dilation, is unilateral in 80% of cases. Whenever we encounter this, we should do a detailed ultrasound examination and also look for the contralateral kidney if there is any renal agenesis, ectopia, or multicystic kidney. The function is moderate or good in majority of the infants, and they can be managed expectantly. Next level of obstruction is the uretero-vesical junction obstruction, where we will see hydroureter and hydronephrosis with a normal bladder. Dilated ureter will look tortuous and it will appear as a collection of cysts of variable degree between the dilated renal pelvis and bladder. Here, the cause can be ureteric stricture or atresia, a vascular obstruction, a diverticulum, or a ureterocele. Next etiology is, the next level is vesico-ureteral reflux. Here we have retrograde flow of urine from the bladder to kidneys, which causes renal damage. It is mainly caused by a failure of the uretero-vesical valve mechanism. It is difficult to diagnose prenatally and usually it is confirmed by a voiding cystourethrogram in postnatal period. The worst of all, LUTO, lower urinary tract obstruction, or also called bladder outlet obstruction. Here on ultrasound, we will note dilated posterior urethra, which is a keyhole sign, megacystis, thickened bladder wall, megaureter, and hydronephrosis. It is usually caused by posterior urethral valve or maybe urethral atresia. It is better if we encounter this, we should do a advice for a CMA. And it carries high perinatal mortality because there is pulmonary hyperplasia secondary to severe oligohydramnios in this situation. If we encounter this, we should offer pregnancy termination because it usually carries a poor prognosis. Now, of all the cases, transient or physiological forms 50 to 70% of cases. Pelvic-ureteric junction obstruction forms 10 to 30%. Uterovesical junction obstruction 5 to 15%. Vesico-ureteral reflux will be seen in 10 to 40%, while posterior urethral valve is seen to 1 to 5% of cases. We do not stop at this. We should know that fetal pylectasis is a soft marker for trisomy 21. So when we have this, we should do a targeted anatomical evaluation of the fetus and we look for all other markers if present. As an isolated finding, it carries a likelihood ratio of 1.5, and this finding should be interpreted in context of the a priori risk of trisomy. Thank you.
Thank you, Shika, for your extensive discussion on urinary tract dilatation.
Thank you, sir.
12 to 15 minutes odd. And we will come back in the question answer session and we will discuss further more on some of the key topics in this. So as of for the time's sake, we will move to the next presentation.
Yes,
It's
sir.
urorectal septal malformation by Dr. Tanaya Acharya.
I will stop sharing, sir.
Yeah, please stop sharing, Tanaya. So Tanaya, she has done fellowship under us, and after completing her fellowship, now she's working as a junior consultant in our Department of Fetal Medicine, and she's also as very passionate about her scan, and she's doing a brilliant job. So let us hear from her about the urorectal septal malformation, which is relatively a complex topic, which she will try to simplify and present in front of us. So Tanaya, please go ahead with your presentation.
Good evening, everyone, my respected seniors and my dear colleagues. At the outset, I would like to thank all the esteemed members of the society for giving me this opportunity to speak in this platform. Today, my topic of discussion will be urorectal septal malformation. So, let's begin with the case. This lady, 28 years old, primigravida, non-consanguineous marriage, came to us for target scan second opinion for severe oligohydramnios and dilated loops of bowel with enteroliths. Her aneuploidy screening report was negative, and she was a known case of hypothyroidism on treatment. On ultrasound examination, her gestational age was 21 weeks 3 days and complete anhydramnios. On fetal abdomen, there were enlarged loops of bowel with multiple intraluminal echogenic foci suggestive of enteroliths. On fetal KUB, left kidney could not be seen in left renal fossa along with the absence of renal artery on color Doppler, suggestive of left renal agenesis, although we could not rule out ectopic kidney. On right side, right kidney was echogenic with renal pelvic dilatation UTD A1. Now we tried to look for bladder and perirenal muscular complex PMC, but could not identify separately because of the suboptimal visualization. Visualization of limb, spine, and heart anatomy was also very suboptimal, and exact characterization was not possible due to the absent Leica situation. On TVS, we looked for head and brain anatomy, and it appeared normal. Now, these are the two pictures. The first one showing the echogenic kidney on the right side with mild dilatation of the renal pelvis, and on the left side the renal fossa was empty, and as we switched on the color Doppler, we can see there was no flow on the left side. Now this is the picture showing the enlarged loop of bowel containing the intraluminal echogenic foci suggestive of rectovesical fistula and enteroliths. Now this is the video loop showing right-sided echogenic kidney, and the left side the renal fossa is empty, and we can see the line down adrenal sign also. Now this is the video showing the enteroliths, the ball-like echogenic structures within the dilated loop of bowel. Then poor fetal prognosis was explained to the couple, and they went for termination of pregnancy and followed by DNA storage from the product of conception. Now, coming to the theory part, urorectal malformation is a very complex congenital abnormality with a very rare incidence of 1 in 50,000 to 1 in 250,000 newborns. It occurs due to the abnormalities in migration and fusion of urorectal septum and the cloacal membrane, which results in persistent cloaca and vesico-urorectal fistula. Now, before going to the details of the various types of urorectal septal malformation, we should understand a little bit about the embryology. So, this is the primitive hindgut, and this is the at the end of the primitive hindgut is the cloaca. So, and this the extraembryonic mesoderm surrounding the twist, it differentiates and proliferates downwards as urorectal septum, and it divides the cloaca into ventral urogenital sinus and dorsal anorectum, and the cloacal membrane also into urogenital membrane and the anal membrane. Eventually, these membranes rupture by apoptosis, resulting in patent perineal and anal opening. Now, depending upon the division and migration of the urorectal septum and also the cloacal membrane, and also depending on the number of perineal orifices, URSM has been explained as 4 types in a spectrum. The most severe variety is the complete URSM, in which there is a complete absence of perineal or anal opening with ambiguous external genitalia, and it is lethal owing to severe renal dysfunction and pulmonary hypoplasia. Then comes partial URSM, in which there is a single perineal or anal opening which drains a common cloaca. It is compatible with life and is amendable to surgical correction after birth. Then urogenital sinus is also in the lower end of the spectrum, in which there is presence of an anal opening and a single perineal opening which drains both the bladder and the vagina. It is also compatible with life and amendable to surgical correction postnatally. Then anterior anus is the least severe variety, in which there are 3 orifices are patent, and there is only hypoplasia of the urorectal septum, for which the anal canal is shifted a bit anteriorly. Now, what are the various prenatal ultrasound features that will hint us towards the diagnosis of URSM? The first is ambiguous genitalia, which my colleague will be discussing in his presentation. And then we will find absence of perianal hypoechoic ring, or PAMC, perianal muscular complex. Then in fetal KUB, we'll find signs of obstructive uropathy like megacystis or urinary tract dilatation. In abdomen, there will be enterolithiasis, fistulous connection, and dilated loops of bowel, ascites. One or more pelvic cysts might be there, causing hydrocolpos due to imperforate hymen or ovarian cysts. Oligohydramnios due to severe renal dysfunction, which will cause fetal compression, eventually limb defects and pulmonary hypoplasia. In spine, there might be defects in the lumbosacral region, and also in cardiovascular system, we might find atrial and ventricular septal defects. Now, I have just added this slide to demonstrate how does a normal perianal muscular complex look like. Until unless we are very much accustomed with the normal finding, we cannot detect the abnormality. So this is the normal target sign which we see in an ultrasound. This is the central hyperechoic anal mucosa, surrounding which is the hypoechoic line of anal sphincter, and the third layer is the circular hyperechoic line, which is the interface between the anal sphincter and the surrounding tissue. Now, in differential diagnosis, we have Vectral syndrome or Vater syndrome and OIS complex. In Vectral syndrome, mostly vertebral and limb defects are more common, and whereas in URSM, genitourinary complications are more, defects are more, and depending on the level of vertebral involvement, thoracolumbar vertebra is more involved in Vectral syndrome, whereas in URSM, sacral vertebra is more involved. Now, regarding the genetics, genetic etiology is not much known. However, various genetic events in these particular genes have been implicated in interference of development of thoracoabdominal and pelvic organs like mostly cardiovascular, urogenital, and gastrointestinal tracts. Thus, amniocentesis or DNA storage from fetal tissue should be advised for further genetic workup. It is just to note that in cases of anorectal malformation, which is also a part of urorectal septal malformation spectrum, which involves imperforate anus without fistula, chromosomal associations with trisomy 21 and 18 has been reported. Regarding the recurrence risk, recurrence of urorectal septal malformation has not been reported in subsequent pregnancies. Thank you.
Okay, thank you, Tanaya, for your comprehensive talk on the urorectal septal malformations. And as usual, it's a little complex topic and a lot of embryological background we have to clear before presenting on it. And you have done, you have justified on this front. And I think again, we'll come back to you for the question answer session.
Okay,
So
sir. Thank you.
we will close here. I think we have completed 3 speakers. So we are midway. And I think we have to go for the trade partner video before we commence on the next 3. Am I? Okay, so welcome back. And one statement I would like to make here, that this SFM platform is such an excellent platform to express ourselves. We were so fortunate to have this platform, and I could see already the number of participants crossing 300 mark. So this is a phenomenal thing. Like on a virtual platform, I don't think so. There are many virtual platform which attracts this kind of attendance, and on a working day evening. So hats off to SFM to organize such great programs and involve all of us, irrespective of our stature, to express ourselves on this platform. Thank you so much. So with this, we would like to continue with the next presentee is Dr. Ishwar Agarwal, and he will be presenting on yet another controversial, complicated topic of ambiguous genitalia. So Ishwar, floor is all yours. Dr. Ishwar, please
Yes, sir.
unmute yourself.
Yes. sir.
Yeah.
Now it's
Yeah,
audible,
please
sir?
carry on.
Yes.
Yeah.
Yes, audible. Please carry on.
Good evening, everyone. Myself, Dr. Ishwar Agarwal, working as a consultant radiologist at Asansol, going to discuss on the topic of ambiguous genitalia. Now, I would like every one of you to go through these 5 images. Aren't these all images looks more or less similar?
Can you
So, but
be a
yet,
bit louder? Sorry, Dr.
uh,
Ishwar.
okay, sir.
Ishwar,
Now,
maybe come closer to the computer.
yes, sir. I would like every one of you to go through these 5 images. Aren't these all 5 images looks more or less similar? Yet the diagnosis of all 5 of them were totally different. The first image was a 46XY male with undervirilized male with bifid scrotum secondary to 5-alpha reductase inhibition. Second case was a 46XY male with severe hypospadias. The third one was 46XS with a left-sided overtestes. The fourth one was a overvirilized 46XX female with fused labia secondary to congenital adrenal hyperplasia. And the fifth one was 46XY with bilateral testes secondary to androgen insensitivity syndrome. So what does it say? It says that phenotypic sex is not always equivalent to genotypic sex. A similar kind of problems we face when we diagnose ambiguous genitalia prenatally. So today we will see how we can follow an algorithmic approach to narrow down our diagnosis. So a patient came to us for a second opinion for external genital abnormality. First trimester screening was positive for Down syndrome. However, amniocentesis report came normal. Now I would like you to go through this video clipping. Here what we can see is there is loss of normal morphology of the external genitalia. We can't exactly say whether it's a bifid scrotum or enlarged labia with clitoromegaly. So we went to a mid sagittal section, and here what we can see is a soft tissue curvilinear structure with ventral angulation. And on color Doppler study, what we can see is a fan shaped of urine jet coming out from the ventral aspect of the penile shaft. Here, what you focus the yellow arrow, we can see a jet of urine coming out from the ventral aspect of the penile shaft. We when then we saw the rectovesical space where we can see that the rectum and the urinary bladder are juxtaposed to each other, suggestive of a male rectovesical interface. The diagnosis of a severe hypospadias with bifid scrotum was made. A clitoromegaly due to virilization was kept as a differential. Patient was counseled about congenital adrenal hyperplasia, familial clustering of hypospadias, and its genetic association. Patient was sent for postnatal evaluation, and counseling was and patient was sent to a multidisciplinary team of doctors. When we tried to contact the couple for postnatal outcome, they were disturbed and denied any information. So definition includes it's a congenital discrepancy between genetic, gonadal, and phenotypic sex. The incidence is 1 to 2%, and the patients requiring surgery is 0.1 to 0.2%. So prenatal reports regarding ambiguous genitalia or atypical genitalia remains quite uncommon. So what are the reasons of underdiagnosis? Insufficient knowledge. Literature says very little about them. Weak evidence. Most of the literatures are based on small sample size. References tables are as proposal without validification, and limited attention. Most of the literature focus on postnatal diagnosis rather than prenatal diagnosis. So can we report ambiguity when we suspect it? What the law says? According to PNDT Act, Form F, where it says that prenatal diagnostic technique like ultrasound and amniocentesis can be used for diagnosis of these 6 abnormalities, out of which sex-linked disorder is one of them. So what IUCOG guidelines which we use routinely says that visualization of genitalia in male and female fetus is optional. So is visualization of cervix, umbilical cord, and even nasal bone evaluation. And we do look at all these structures. So why shouldn't we look at the genitalia? Recently, IOCOG guidelines also says that looking at the normal fetal genitalia is a good practice point. According to IUM guidelines, it also says that we can see the external genitalia in multiple gestation and when medically indicated. So let's go to a bit of embryology. In XY fetus, due to presence of SRY gene on Y chromosome, it acts on the bipotential gonads and leads Sertoli cells to stimulate anti-Mullerian hormones, which eventually leads to degeneration of Mullerian duct and development of Wolffian duct, leading to male internal and external genitalia. Similarly, in female, in the absence of SRY gene, there is degeneration of Wolffian duct, and the X chromosome and autosomal genes together act to lead to development of female internal and external genitalia. Here, what we can see is it's not only SRY gene, but a cascade of multiple genes, which are mostly located on autosomes, are also they act together for normal development of genitalia. And defect in any one of the genes will lead to ambiguity. Here, there is development of external genitalia. Cloacal fold on either side of cloaca fuse entirely to form the genital tubercle, which leads to clitoris in female and glans in male. The urogenital folds and labioscrotal folds fuse together in males to form scrotum, and in females, it remains most of it remains unfused to form labia majora and minora. So let's look at the normal anatomy at second trimester. We can directly visualize the external genitalia after 16 weeks. In males, we see a small semicircular structure representing penis and with a pointed tip representing the glans. The scrotum is well visualized, and testes could be visualized only in third trimester after 25 weeks. In females, we see 4 echogenic parallel lines, which is consistent with labia majora and minora. So here in this 6 images, we can see in the first image, we can see that the penile shaft with pointed tip representing the glans. In the second image, we can see scrotum with the penile shaft. The third image shows 4 echogenic line representing labia majora and minora. In the fourth image, in third trimester, we can see the scrotum with both the testes and the penile shaft. The fifth image shows the enlargement of labia majora in third trimester, giving a coffee bean appearance. And on the color Doppler study, we can see a jet of urine coming out from the penile shaft. So there are some additional signs which can we use in the ultrasound. It includes testicular descent, which we see only after 25 weeks, fetal scrotum and penile size, visualization of micturition in males, which we use for hypospadias, rectovesical space, and anogenital distance. What we routinely use is this rectovesical space. So rectovesical space, here in the first image, we can see that the rectum and the bladder are juxtaposed to each other with very little space in between, pointing towards a male rectovesical interspace. In the second image, we can see there is a soft tissue structure between the bladder and the rectum, which increase the rectovesical distance. and pointing towards a female rectovesical interspace. Now, classification. Classification includes sex chromosomal DHD, XY DHD, and XX DHD. In XX DHD, suggestive of musculization of genetically female fetus. There are multiple causes, the most common cause being congenital adrenal hyperplasia, secondary to 21 hydroxylase deficiency. Then in ultrasound, we see an enlarged clitoris, redundant or incompletely separated or fused labia majora. There are multiple genetic association, which can be chromosomal, deletion, imprinting disorder, and syndromic conditions. So clitoromegaly is the most common uh, ambiguity seen in female XX DHD, where we see abnormal enlargement of clitoris. And according to Chickeralt et al., we can diagnose clitoromegaly when the clitoris is 5 or more beyond the labia majora. It can be hormonal, non-hormonal pseudoclitoromegaly or idiopathic. Congenital adrenal hyperplasia being most common of them. Now we come to XYDHD. XYDHD is under-virilization of male. There are numerous etiology being abnormality of testicular formation due to SRY gene mutation, abnormality in testosterone production, abnormality in synthesis of testosterone, abnormal conversion of testosterone to testosterone in external genitalia due to 5-alpha reductase deficiency, and abnormal or lack of response to testosterone due to partial or complete androgen insensitivity. In ultrasound, we see an abnormal phallic structure being absent or short, scrotum being absent or bifid, and undescended testes after 32 to 36 weeks. In genetics, regarding genetics, we see SRY gene mutation or sex chromosomal aneuploidy. The hypospadias being the most common XYDHD. Here, what we see an congenital defect of male genitalia where the urethral meatus is positioned in abnormally location along the length of ventral shaft of the penis. Here are the various grading. It is normally associated with CODY, and we can diagnose a fan shaft of urine coming out from the ventral aspect of the penile shaft. Here is the case. Here is the case of a micropenis, where we can see an abnormally small penis with normal configuration. There are a variety of factors, including hormonal, developmental, or genetic syndrome associated with it. Now, there are two pictures, including short phallus with a bifid scrotum and a penoscrotal transposition where the scrotum lies above the penis. There are numerous syndromic association with ambiguous genitalia, which can be associated, and we should look at all this. Now, it is very difficult to differentiate between a virilized male from an early virilized female from an early virilized male, whether it's a small penis or a hypospadias or a clitoromegaly. So we should use all the points, whether where is the meatal position, testis is present or not, rectovesical distance, and whether uterus is present or not. And using all this, we can differentiate these features. Factors affecting identification of fetal sex includes maternal obesity, low amniotic fluid volume, presence of umbilical cord, and unfavorable fetal position. So there is an algorithmic approach to a diagnosis of ambiguous genitalia. First, we'll divide whether it's an isolated or a non-isolated thing. When there is it's a non-isolated, we'll rule out chromosomal or syndromic conditions or single gene disorders. In isolated cases, we'll see whether it is associated with IUGR. If it's associated with IUGR, we'll rule out mosaicism and chromosomal abnormalities. And if it's a normal growth, it can be an XX or an XY DSG. We'll look at the rectovesical interspace and do the differential diagnosis. Prenatal diagnostic approach should also include pregnancy history, where we will look for whether mother is having hirsutism or clitoromegaly, mother is having any history of intake of any teratogenic drug or androgenic drug, family history, whether family members having history of any genital abnormalities, consanguinity is there or not, which increases the risk of autosomal recessive disorders. And we do the lab investigation, which includes amniocentesis and amniotic fluid hormonal studies. We do compilation of all the information and go to the differential diagnosis. Regarding counseling, the two things which I would like to say that in isolated cases, we should tell the parents that there are multiple treatable conditions that can result in atypical genitalia, and and to reassure them that a good outcome can be anticipated. Postnatal management includes we will send the patient to a multidisciplinary team of doctors, including pediatrician, geneticist, urologist, and others. One thing I would like to say is that we should all start looking at the normal genitalia in every scan. If we don't see it, we won't be able to pick our first cases of ambiguity. Thank you, everyone.
Thank you, Ishwar, for your message and maintaining the ambiguity of ambiguous genitalia. And I'm sure people will be itching to rub you left, right, and center with their questions in your Q&A box. So with this, We'll move on to the next presentation on autosomal dominant polycystic kidney disease by Dr. Deblina. Deblina, are you there?
Good evening, everybody. Today I shall.
Good evening.
Hello, am I audible?
Yeah, you're audible. Please go ahead.
Okay. Good evening. Today I shall present a case of prenatal diagnosis of autosomal dominant polycystic kidney disease, which is the most common genetic nephropathy. Autosomal dominant polycystic kidney disease is the most common genetic nephropathy with an incidence of 1 in 1,000. It usually presents after the third or fourth decade of life. It becomes symptomatic after that, but it may complicate right from childhood with abdominal pain, hypertension, or proteinuria. Most of this case will ultimately progress to end-stage renal disease and may require renal replacement therapy and subsequently renal transplantation. Coming to the case, a 34-year-old primigravida came for prenatal genetic diagnosis of probable autosomal dominant polycystic kidney disease in the fetus at 21 weeks because the husband, who had symptoms of hypertension and abdominal pain from 30 years of age, was diagnosed with ADPKD and now have a deranged kidney function. It was a non-consanguineous marriage. The FTS was low risk and all other antenatal investigations were within normal limit. On pedigree analysis, the husband's mother, maternal aunt, and maternal cousins were also found to be affected by similar presentation of autosomal dominant polycystic kidney disease. We carried investigations on the mother. On mid-trimester ultrasound of the fetus, it was found to have isolated bilateral echogenic kidney with accentuated corticomedullary differentiation. That is, brighter cortex was present. There was no other anomaly detected. The liquor volume was normal and the bladder was visible. On ultrasound KUB of the father, we found bilaterally enlarged kidney with lobulated outline, multiple non-communicating cysts with dilated parenchyma. So we proceeded with the genetic test to confirm the diagnosis. We went forward with amniocentesis and whole exome sequencing of the sample and also of the father. The whole exome sequence of the father revealed a heterogeneous nonsense mutation in the heterozygous nonsense mutation in the PKD1 gene, which was deemed pathogenic. Unfortunately, in the fetus, the same pathogenic mutation was present. On top of that, another heterozygous missense mutation was also detected in the PKD1 gene, which was a variant of unknown significance. With this information, we counseled the patient that the fetus was likely to have the same phenotypic expression as that of the father, and that early diagnosis and treatment with novel therapy will delay the onset of end-stage renal disease and complications like hypertension, abdominal pain, and that no prevention is available at present, and there will be 50% chance of recurrence in all subsequent pregnancy because of the autosomal dominant nature of the disease. The couple took informed decision of not to continue the pregnancy and opted for medical termination of pregnancy. So coming to the discussion, autosomal dominant polycystic kidney disease usually presents with bilaterally enlarged hyperechoic kidneys. It becomes symptomatic between the third to fourth decade of life, and by the fifth or sixth decade of life, it may progress into end-stage renal disease. There is 50% recurrence because of the autosomal dominant nature. It is caused by mutation of PKD1 gene, which is located in the chromosome 16 and results to most of the cases, that is almost 85%. In case of PKD1 gene, there is early onset severe end-stage renal disease. 15% of the cases are caused by mutation of the PKD2 gene, which is located on the chromosome 4. And this subset have a late onset of end-stage renal disease. Another small subset is caused due to mutation of the GANAB gene, which is located in the chromosome 11. Now, the PKD1 gene and the PKD2 gene will encode for transmembrane protein called polycystin-1 and polycystin-2, which are located in the cilia of the renal tubule, and it is responsible for maintaining the function of the renal tubules. the current theory regarding pathogenesis of ADPKD is that it is caused by second hit mutation. What is second hit mutation theory? Basically, the first hit or mutation occurs during the germline mutation, and it is inherited or de novo. And because the PKD1 and PKD2 genes are susceptible to new mutations, the second hit will occur because of newer somatic mutation at any point of the lifetime. And after this second hit or the second somatic mutation, there will be cystic change in the kidney resulting in ADPKD. There are a few extrarenal manifestations of ADPKD, like in the brain, we can get intracranial aneurysms or arachnoid cyst. Congenital heart disease may present in form of mitral valve prolapse or dilatation of aortic root. In the liver, there may be liver cyst in as many as 80% cases. The liver cysts are usually peripheral and not related with the biliary duct. There may be pancreatic cyst, and there may be seminal vesicle cyst or testicular cyst and abdominal wall hernias. So once a diagnosis of ADPKD is made, antenatal ultrasound for assessment of renal anatomy and amniotic fluid volume is mandatory every 4 weekly till delivery. It is essential to offer a kidney ultrasound to both the parents, and if the expected mother is found to have ADPKD, the nephrological workup and close monitoring is indicated for early identification of obstetric complications like hypertension or preeclampsia. And the rest of the obstetric care is standard, and the timing of delivery is also standard. It can be induced at term. So coming to the prognosis, we have to keep in mind that the current prognosis is based on patients who were born decades ago, and they did not have the same level of care which is available today. The newborns who are diagnosed with ADPKD now are probably going to have a better outcome in future because of early diagnosis and treatment with novel therapies, which will delay the end-stage renal disease. It is found that vasopressin and associated cyclic AMP-related signaling pathway are important contributors for cyst growth in ADPKD. Hence, vasopressin antagonists like tolvaptan has been found to decrease the rate of growth of renal volume and also slow the decline of kidney function. Hypertension is the most important modifiable risk factor in case of ADPKD, and better blood control will also slow down the disease progression. Angiotensin converting enzymes inhibitor and angiotensin 2 receptor blockers are the recommended drugs for treatment of hypertension, and the patient will ultimately require renal replacement therapy at some point during adult life. Coming to the differential diagnosis, the most common differential diagnosis will be autosomal recessive polycystic kidney disease. This is a very rare disease because of the recessive nature. Incidence is around 1 in 80,000, 1 in 25,000. And there will be bilateral enlarged echogenic kidney with reduced corticomedullary differentiation, on contrast to the autosomal dominant disease. And there might be even hypoechoic outer cortical rim. There is associated severe oligohydramnios and non-visibility of the renal pelvis and the bladder. The other DD which comes to mind is a multicystic dysplastic kidney, which may be isolated, and it is usually unilateral. And if it is bilateral, it may be associated with other syndromes like Meckel-Gruber syndrome, a Beck-Widman syndrome, a Bardet-Biedl syndrome, and Perlman syndrome. So what are the take-home message from this case? Prenatal diagnosis of ADPKD solely by ultrasound is very rare. Confirmation is to be done by whole exome sequencing or Sanger sequencing, whichever is fit for this. If the disease is confirmed, a 4-weekly ultrasound is to be done to assess the renal anatomy and the amniotic fluid volume. If we have it will have a significant psychosocial implications for the patient due to the uncertainty of the disease course, and hence genetic counseling and multidisciplinary approach is crucial for providing information regarding the implication of the diagnosis, future management, and subsequent family planning. Because of the hereditary nature of the disease, we may provide alternatives like pre-implantation genetic diagnosis and in vitro fertilization or gamete donation to the afflicted parents. Thank you.
Thank you, Deblina, for your in-depth discussion on a relatively very rare prenatal diagnosis. And I remember still that at one point of time, when we looked at the kidney of the fetus, there was inter-observer disagreement whether it is ecogenic, not ecogenic.
Yes, sir.
And then thanks to the husband that it was a known case, and then we started up working and we got the diagnosis. So thank you for your excellent deliberation on this topic. So with this, we will come to the end of our last presentation, which is on embryological disorder of the kidney by Dr. Bijoy Mukherjee. Dr. Bijoy, floor is all yours. Please carry on.
Good evening, everyone. Hello, am I audible?
Yeah, you're audible. Please carry on. Please
Okay.
continue, Bijoy. You're audible.
Thank you for this opportunity. I'm presenting the embryological disorders of kidney. The embryological disorders can be classified as follows. Abnormalities in renal number, including supernumerary kidney, renal agenesis. The abnormality in renal position, including renal ectopia, horseshoe kidney, or malrotation. Abnormality in ureteral number, including the ureteral duplication. Abnormality in ureteral position, including the ureteral ectopia, displacement or deviation. Bladder abnormalities, including bladder agenesis or bladder exstrophy, and urethral abnormalities, including urethral atresia or double urethra. Coming to the first case, primi gravida, 30 years of age with non-consanguineous marriage and no significant medical history with a low risk of first trimester screening, came to us for a routine anomaly scan. On ultrasound, we could see an empty right-sided renal fossa, while the left renal artery was seen to be supplying kidney in the renal fossa. On the right-hand side, we could see the lying down adrenals. So in this video, we can see the left renal artery supplying the kidney in the left side, which is placed in the renal fossa. There was absence of renal tissue on the right side and absence of Doppler signal on that side. No urogenital or skeletal anomalies were noted, and no ectopic renal tissue was noted elsewhere, so we could assume it to be a case of renal agenesis unilateral. We counseled the couple that such case is rarely associated with chromosomal genetic syndromes in 1 to 2% cases and single gene disorders in 5 to 7% cases. The long-term outcome is usually good. Postnatally, this case was confirmed to have unilateral renal agenesis. So whenever on ultrasound we see an empty renal fossa, we may assume it to be a case of renal agenesis, but first we have to rule out ectopic kidney to confirmatively say so. There will be absent Doppler signal on the side where there is absence of renal tissue, and lying down adrenal sign will be seen on that side. Renal agenesis can be unilateral or bilateral. In unilateral renal agenesis is usually it is of less clinical significance, while bilateral renal agenesis presents with anhydramnios, pulmonary hypoplasia, and Potter's species, and it is usually lethal. It occurs because of the failure of interaction between the ureteric bud and metanephric blastema. 30 to 40% cases with unilateral renal agenesis have developmental anomalies like GIT, cardiovascular, and musculoskeletal abnormalities. 25% cases have vesicoureteric reflux, and pelviureteric junction obstruction is less common. We know the lying down adrenal sign is usually present when a kidney is absent in the renal fossa. However, there are some exceptions to this rule. On the left-hand side image, we can see a Y-shaped adrenal gland which is present in absence of kidney in the renal fossa. So it is hypothesized that a kidney may have naturally developed here, which later became dysplastic and gradually disappeared. There is also a pseudo-exception. Here the adrenal gland looks normal, but it is only because the crus of the diaphragm simulates the adrenal limb. So in the absence of renal tissue, there is the lying down adrenal gland, which touches the crus of the diaphragm, and thereby it is giving a normal looking adrenal gland appearance, while in reality it is only the lying down adrenals. Coming to the next case, primi gravida, 27 years of age, with non-consanguineous marriage, with no significant personal or family history, and a low risk of first trimester screening, came to us with an anomaly scan reporting elsewhere a differential of horseshoe kidney or unilateral renal agenesis or cross-fused ectopic kidney and unilateral clubfoot. On ultrasound, we could see an empty renal fossa on the right side, while the left side kidney was present to be seen in the renal fossa, and visualization of the left renal artery was seen. So we could see one kidney in the renal fossa, while there was one ectopic kidney which was placed in the midline transversely and fused with the normal kidney. In the right-hand side image, I have delineated the ectopic kidney which is placed transversely in the midline. The normal kidney which was placed in the renal fossa was supplied by the renal artery, whereas the ectopic kidney which was present in the midline was found to be supplied from a branch from iliac artery. So in this video, we can see one kidney is placed in the renal fossa, while another kidney is placed transversely and in the midline fused with the normal kidney. There is absence of renal tissue in the contralateral fossa. So it is a case of crossed fused ectopic kidney. Unilateral CTV was associated with it. No other skeletal abnormalities were seen. Target sign was noted. So we counseled the couple for follow-up scans every 4 to 6 weeks in order to detect the development of hydronephrosis or vesicoureteric reflux. Amniocentesis was offered to the couple in view of talipus and crossed fused ectopic kidney. The genetic tests came out to be normal. Postnatally, this case was confirmed to have a crossed fused ectopic kidney, and there was no evidence of hydronephrosis till 1 year of age. So ectopic kidney can be classified into simple renal ectopia and crossed renal ectopia. In simple renal ectopia, the kidney is absent in the renal fossa, but present on the same side of the ureteric orifice, either in the pelvis, iliac region, abdomen, or chest. In crossed renal ectopia, the kidney is present in the opposite side of the ureteric orifice. It is usually present below the aortic bifurcation and is supplied by iliac or the infrarenal artery. In crossed-fused ectopia, it could be associated with pelviureteric junction obstruction or vesicoureteric reflux in 58% of the cases, and follow-up scans are required every 4 to 6 weeks to detect the development of hydronephrosis. Postnatal assessment, we need MCU or DMSS scan in order to check the development of hydronephrosis and its severity. The postnatal management is usually done according to symptoms. There is no need to separate the fused units. Only in case of severe pelviureteric junction obstruction, pyeloplasty may be needed, and in severe vesicoureteric reflux, ureteric reimplantation may be needed. In crossed-fused ectopic, the kidney can assume various shapes. In our case, this was a case of L-shaped kidney, where one kidney was placed in the normal fossa, while the other kidney was placed midline, transversely, and fused with it, thereby assuming an L shape. Coming to the next case, Gravida 2, Para 1, Life 1, 30 years of age with non-consanguineous marriage, no significant personal or family history, and a low risk of first trimester screening was referred to us in view of renal abnormality. So in this video, we can see that the lower poles of the kidneys are not very well defined. There is presence of isthmus of renal tissue in between the two kidneys, and the renal pelvis can be seen to be anteriorly rotated. So it is a case of horseshoe kidney. In this video, we can see the bifurcation of the aorta and presence of isthmus of renal tissue in front of the aorta. Intra-abdominal calcifications in liver and spleen parenchyma were associated with it. There was no CVS or skeletal abnormalities noted. Target sign was seen. So we counseled the couple for amniocentesis because this case can be associated with genetic syndromes and extrarenal abnormalities. Follow-up scans were advised every 4 to 6 weeks in order to detect the development of hydronephrosis or vesicoureteric reflux. The microarray report came out to be normal. So horseshoe kidney is the most common fusion anomaly of the kidney, occurring in 1 in 400 cases. The lower poles of the kidney are fused with an isthmus of renal or fibrous tissue, and it is trapped under the inferior mesenteric artery, which arrests the further ascent and rotation. Thereby, it results in a lower location of the kidneys and an anteriorly facing pelvis. On ultrasound, we can see a fused lower pole and an abnormal longitudinal axis. The fused isthmus here is the most conclusive finding. So there is this entity, that is the renal pelvic angle, where on axial section, we measure the angle between the two renal pelvises. In normal kidney, the renal pelvic angle is more than 140 degree, while in horseshoe kidney, it is less than 140 degree. And it is a simple entity that can distinguish the horseshoe kidney from the normal kidney. Horseshoe kidney can be associated with Turner syndrome, trisomy 18, trisomy 9. Extrarenal anomalies like cardiovascular, musculoskeletal, and CNS abnormalities can be associated. Vesicoureteric reflux, duplication of the ureters, hypospadias, undescended testis, biconvate, or septate uterus may be associated. Though 60% cases are asymptomatic, postnatal follow-up is advised because this case is more prone to hydronephrosis, renal calculi, and infection. There is also an increased background risk of cancer, including transitional cell carcinoma, Wilms tumor, and carcinoid tumor. Thank you.
Okay, thank you, Vijaya, for your excellent talk on the embryological disorders of the kidney. So with this, we have come to the end of our 6 talks from 6 young guns. And I'm pretty sure that all of you at the end will appreciate their hard work behind it. And they have taken us right from basics to the advanced, and also they have tried to maintain the time. So hats off to all the 6 young guns for such a nice and excellent presentation on difficult talks. And now I would like to request Dr. Alok Vashne to take up the question answers and try to answer most of the question answers. So I think it will be better that the respective speakers they try to answer, but it should be a quick fire because for the sake of time. And any difficult questions, then the guns are always there behind to answer them. Thank you so much. Alok, please
Yeah.
take us through the Q&A.
Thanks, Dr. Kushid. Thank you. Kudos to all the young presenters. This was like a mini symposium presented by the young guns. But it felt like these are not young guns, but seasoned presenters who are presenting on all these topics. Great presentations detailing imaging findings, workup, differential diagnosis, follow-up, genetics, etc., etc. Excellent, excellent, truly excellent. And I particularly like that these guys, they chose common topics, daily practice topics, which we encounter on day-to-day basis rather than some, esoteric, rare cases. Okay, so this was extremely nice. And thank you, SFM Bengal team, for doing this, organizing all this, Shankar, Dr. Sita, Prasanna, Kanchanda. And thanks a lot to you, Kushid, for mentoring all these young guns in for their case selections, presentations, and all the hard work is yours actually. Kushid, I would request you to, continue moderating
Yeah.
because I'm suffering from a bout of URI. My voice is,
Okay.
trembling a little bit. I'll be pitching in
Okay.
wherever required, but I would, ask you to please continue with the questions as well. Thank you so much.
Okay. Okay. Thank you so much, Alok. Now, there are a lot of um appreciation from the attendees. Excellent presentation, superb, excellent talks, mind-blowing, nice presentations. So I'm not going to read all of them. Okay. So we will just go one by one, and we will take only those questions which were relevant to this segment of presentation. Okay. So the first question from Dr. Kiran, that is it mandatory to go for the genetic analysis with amnio for ecogenic kidneys with no other abnormalities in the scan? So Vinayak, would you like to answer this question? It's a quick fire. Okay, so we can
I
move
feel
to the next
we should
question.
go for a genetic testing, even if it's an isolated bilateral ecogenic kidneys, because there is an association with trisomy 9 and 13 and also 17q deletions. Sir.
Okay, so here 17q deletion is also very important because in trisomy 13, 18, you will get some phenotypic abnormality on ultrasound. But when you look at the chromosome 17q or HNF1 beta, so it may be completely very innocent looking, just an ecogenic kidney with normal liker, normal anatomy, or sometimes a little bit paradoxically increased liker. And you must go for at least a baseline chromosomal microarray with DNA storage. And if you find any other associated extrarenal abnormality, then you may think of certain syndromic conditions as Dr. Vinayak has shown. and also look for the ciliopathy if there are additional abnormalities in the form of a skeletal or eye abnormality, so things, so on and so forth. So can we diagnose the genetic abnormality by NIPT instead of amniocentesis? Again, Vinayak, would you like to answer this?
No, absolutely not. NIPT was only validated for 13, 18, 21, and sex chromosome abnormalities, deletion and duplication cannot be diagnosed. And after all, sensitivity and specificity of NIPT is not 100%. So I would definitely suggest and insist the patient to go for invasive testing.
Yeah, and especially whenever there is any obvious structural abnormality, so there's no point of going for the screening test. We must go for a confirmatory test, right? So, Shika,
Yes, sir.
can we differentiate PUJ obstruction versus mild hydronephrosis on antenatal scan?
So hydronephrosis is basically the back pressure of this obstruction in the kidney. It is a sign. And PUJ obstruction, we're trying to delineate what is the etiology, like what is the level of obstruction behind it.
Yes. Yeah, absolutely,
So,
absolutely. So
so
PUJ
both are
obstruction just
different
is
entities.
correct,
Mhm.
correct,
Mhm.
correct. Okay, fine. So again, just to carry on, so in impression, we should use UTD A1, A2, A3 terms instead of pileectasis or hydronephrosis.
No, it has to be a consistent use of the term UTD, either A1 or A2,
Okay.
A3, instead of any other term, because they all have a different implied meaning.
Yeah, you have already shown a slide on that,
Yes.
clarifying that.
We should not use any
Okay.
of the term other than UTD.
Okay. So, my friend Dr. Sharad Gupta, he always poses little long question. So let me go through it. In case of severe urinary tract dilatation, like gross hydronephrosis or over distended urinary bladder, should we do antenatal sonographic MCU to come to a final diagnosis and refer to higher center for antenatal management like vesicoamniotic shunts or fulguration? Or should we wait for the fetus to get delivered and manage postnatally? I want to ask how successful is antenatal management and should we offer to patients or not?
Sir,
So,
actually,
what
for
did you
sir, actually for this there was a randomized trial, Pluto, which was done in 2006 or something for 4 years. It was percutaneous vesicoamniotic shunting versus conservative management for fetal lower urinary tract obstruction, and they found that irrespective of whether vesicoamniotic shunting is done or not, there is not much the newborns surviving without with normal renal function. There is not much difference. They basically evaluated some 31 pregnant women with male babies to see what is the difference between two and see what is the survival at 28 days. Uh, Something like that, 28 days. They did not find much difference, whether irrespective of whether you do this shunting or not. Prognosis is not good.
So anyway, it was terminated midway.
Yes.
Now, yeah, just I would like to further add to this. When Sharad is saying antenatal sonographic MCU, okay, so there is there's a concept behind that, that if you are looking at a bladder which is over distended and you keyhole sign,
Yes.
you cannot be sure that this is posterior urethral valve because the predictive value is close to 50% for the keyhole to predict posterior urethral valve. Okay,
Yes.
it may be seen in cases of urethral atresia and even the detrusor muscle instability and other stuffs. So what one of the articles said that you go with the transperineal view and you wait
Mm.
for the bladder maturation, and
Yeah.
once the fetus starts maturating, if there is bulge of the posterior urethra,
Mm-hmm.
then it's a very pathognomic for the posterior urethral valve.
Urethral valve.
So yeah, so if you see a boy with keyhole and with posterior urethra bulging when the fetus is maturating, so these combination are more predictive for the posterior urethral valve as much as close to 90%. And only in this particular subset of cases, to relieve the lower urinary tract obstruction, you may go for a cystoscopy to see if there are really the posterior urethral valves where you can do the fulguration. Okay. And as far as vesicoamniotic shunting is concerned, it's just a palliative measure in those cases where you cannot perform or you don't have the facility or skill to do cystoscopic guided fulguration. You can at least relieve the pressure and create a normal kind of amniotic fluid. But then the question is how much the kidney has already been damaged before you intervene that.
Yes.
So there is a big dilemma, and kidney is a very plastic organ. So what it pretends on ultrasound may not be the reality. Okay, so these are real-time difficult questions to answer and needs a multidisciplinary team and the experience to handle such situations. Okay, so we'll move with the next. Severe pylectasis is an indication for invasive testing. Do you think yes or no?
So basically, it has to be seen in totality of what the aneuploid ID screening has been done before or not. If there are any other soft markers which are present, it has a likelihood ratio. If the aneuploid ID screening is done, we divide it with that with the likelihood ratio to see what is the modified ratio now, and accordingly decide
Okay.
on whether it is needed or not. And if there are any other soft markers are there along with it. Isolated
Okay.
pylectasis, if aneuploid ID screening is already done, then no.
So are you going to modify the aneuploidy risk? Like you
If
have
the
a background
modified
risk,
risk
a priori
ratio
risk?
also comes low risk, then it is not needed. We can only follow up.
Okay, so whenever you see pylectasis and rest entire anatomy is normal and a screening has been done, so the background risk has to be adjusted to this pylectasis by using the dynamic calculator and see the new risk. And if this is low risk, then we can just keep following it up. If it comes in intermediate or high risk by virtue of pylectasis, then we need to do certain things. But the likelihood ratio is not that high to modify in all the cases.
Yes.
So yeah, so megacystis of size 26 millimeter at 13 weeks. What
What
will be the prognosis?
Okay, now
Good,
megacystis
bad, good, bad, that's
so bad. Megacystis
bad. That's it.
is up till 7 to 15. It is usually said because of aneuploidies. Anything above 15 is usually said because of an underlying uropathy. And mostly 26 mm and all, they all will further go for the dysplastic kidneys and hydronephrosis and dysplastic kidney.
Yeah,
So it's not that
yeah,
good of
that
a
is,
prognosis.
yeah, that is huge.
Yes.
And what will be the bladder wall thickness if it is thickened?
2 mm, 2 to 3 mm. More than that?
Okay, so do you measure bladder wall thickness or is it subjective assessment?
We can measure, sir. More so it is a subjective assessment. But
Okay.
we can measure it. If it is more than 2 mm, anytime in pregnancy is said to be thickened.
Yeah, and if you want to measure it, the best way to measure is you switch on the color Doppler, allow the umbilical artery to hug the bladder wall, and then
Yes.
you have a clear delineation of the wall and you measure it. Okay.
Measure it.
Now at 21 weeks, unilateral UTD A1, renal pelvic diameter 5 millimeter, should be used to calculate the risk, or is it only when it is bilateral?
Any unilateral or bilateral. Pylectasis is pylectasis.
Okay. Is it justifiable to do amniocentesis for genetic evaluation in case of echogenic kidneys, Vinayak, with moderate to severe oligohydramnios? Amniocentesis for echogenic kidney with moderate to severe oligohydramnios.
Sorry, sir. I couldn't hear you, sir. Sir?
No, is it justifiable to do amniocentesis for genetic evaluation in case of echogenic kidneys with moderate to severe oligohydramnios?
In severe oligohydramnios, sir, I think we should avoid amniocentesis at that moment, sir. And
Yeah.
in moderate cases, we can still go for invasive testing, but sir, the fluid collection will be a difficult technical challenge will be there, sir.
Right. At 21 weeks, if renal pelvic diameter 8 millimeter unilateral, then should be used for risk calculation, or I think you have answered. This is again the repetition. Then Shankar has said, why very nicely presented. Dr. KP Singh, excellent talk by Tanaya. Nova Singh, excellent talk by Shikha. Excellent talks by all. Again, Sharad has come back. Can you please, just a minute. Sharad has a question. Can you please tell the standardized way of measurement of diameter of renal pelvis in the neonate for serial monitoring of the dilated renal pelvis, as they sometimes appear in very different shapes and there happens a lot of interobserver variation in the measurement. So Sharad, I will answer this question for you.
Okay.
Like there is always a difference between antenatal and postnatal measurement criteria. So when we are measuring antenatal, Shikha has already told the standardization. And in the postnatal, when we are measuring the renal pelvis, it has to be only the intrarenal portion of the renal pelvis. It's
Not
not the
extrarenal.
maximum dilatation, which may be the extrarenal. So always you join an imaginary line across so that you are not outside the renal outline, and then you measure the renal pelvis. Otherwise, if somebody is measuring the intrarenal portion of the renal pelvis and somebody is measuring the extra-renal, there will always be a lot of difference and mischaracterization. Anything to add, Shika, on this?
So that is what in when we are doing in fetal life, cannot differentiate in intra and extra renal. So here we will take only the maximum diameter. But after baby is born, we do intrarenal measurement. And there was also a paper that I was reading of whether to do it in supine or prone position. There have been comparisons in between, but what has been said that like if you're measuring in supine, always follow up in supine. If you're measuring in prone, always follow up in prone. That is the only thing I know about it.
Yeah, and actual reality is when you're trying to measure, baby is jumping, crying, making all sorts of movement. So you have to capture the image as you get,
As
and then you try to get the best measurements.
yes.
Okay, so that is the reality. So, okay, if at 20 weeks bilateral APRPD is 15 millimeter, at 20 weeks it is 15 millimeter with no other system involvement, how to counsel the patient and prognosticate? Okay.
So this goes to class UTD 823, and if there is no other features, you like bladder is normal, liquor is normal, then we can follow up this pregnancy like from this scan, repeat a scan 4 to 6 weeks later, and then henceforth depending on what are the findings. Also look in totality, look for any other soft markers, look for aneuploidy screening is done or not. If it is done, then modify the risk and accordingly go on.
Okay, so from 20 weeks, when will you call this patient next?
Another
If
four
it
to
is
six
15
weeks,
millimeter,
maybe 6 weeks,
4 to
sir.
6 will. Yeah, because it doesn't matter.
We
Because it
won't
doesn't
do
matter
anything
anyway. We are
much before
continuing the
that.
pregnancy.
So 6 weeks
It
is
only
fine.
yeah, too frequently calling only creates anxiety,
Yes, maybe six
right?
weeks and after that 32 weeks probably.
So any RPD measurement applicable in first trimester?
No, this is from
No, not
16
as
weeks.
such. It's from 16 weeks. It's just a subjective. If you're looking at the first trimester, then Shankar has again complimented Ishwar, and there's a lot of appreciation for Ishwar here. And with appreciation comes some difficult questions. So here it is, Ishwar, for you. Should we give ambiguous genitalia as a diagnosis or specific mention of sex-specific term like clitoromegaly? Will there be issue related to PCP and DT?
The laws do say us that we can look at the sex and diagnose the sex related disorders. And if we narrow down the diagnosis, it helps us in doing the genetic testings. It even helps us in management and even counseling of the parents. In cases of clitoromegaly, which can be associated with congenital adrenal hyperplasia, life-threatening conditions, salt-losing life-threatening condition can come at birth. So patients we should be ready with the management, and even counseling of the parents can be done. That it can be a transient thing, or there are there are treatment available for this like that. Sir.
Okay. Here I would like to involve our old guns because this is something which very often comes and we are very hesitant whether to write it, not write it, or just mention verbally to the patient because we're all scared of this PCP and DT. Despite whatever we know and understand about it, we always want to play safe. So to Sita, to Alok, to Dr. Mohit sir, that whenever we see an atypical or ambiguous genitalia, should we be writing on our report and discussing the same with the patient? What do you feel in your experience and PCP and DT law says, sir?
So this is a question that arises very, very often.
Yes.
So, but see, on one hand, we want to be, right and do right by our patients. But on the other hand, the gun of PCP entity is too big. Okay, so let's take the middle path. Let's not commit on paper. let's leave ambiguity there and write it as ambiguous genitalia. But
Okay, now the boss has come.
yes,
So,
but
yeah,
the
so okay, you finish it.
yeah,
Please carry on.
but still, I would say that on paper you write ambiguity, but counsel the parents and counsel the doctor and tell them this is what you're thinking, this is what your provisional diagnosis is, so that uh, obviously we do not want things to be lost in translation, but we also do not want to spend years facing inquiries and court cases and whatnot.
So we would like to hear from the boss. Please, sir. Ashok, sir. Please
Thank
clarify
you.
for us.
First of all, congratulations for a hugely successful program. I know how much effort goes into this, and Khurshid, thank you very much for organizing
Thank you,
this,
sir.
mentoring this under the guidance of the entire Bengal chapter, and for Alok Varshni for being omnipresent man for all the problems we have these days in making sure that we keep moving forward at a different pace. Congratulations. When it comes to this particular problem, there is exactly as Alok mentioned, there is science and there is reality. And in our part of the world, science has to take a back seat because of the inconvenience of reality, which means that under the PCP and DT Act, I can specifically mention clitoralomegaly, I can specifically mention hypospadias, I can mention scrotum, I can mention everything. True. The other side of the story is very simple, and that is that most of the times we seem to face a problem with the bureaucracy because of problems of psychology. Now in the district that I work in, we're very, very fortunate. But in other districts all over the country, the moment people get an opportunity to harass somebody, we know that has been translated into an opportunity to harass somebody, and those cases can linger on forever and ever and ever. And then the trial then is not by science or by law, but by social media and by harassment in everyday life. And that is something that is not worth it. So if you are looking at reality, I would suggest we all be aware of it and better to avoid these situations rather than get into them. Of course, some of us have the privilege, like we do in our part of the country, where we have an extremely supportive PCP and DD department, but that does not apply to the rest of the land, unfortunately.
So just another quick question. The
Yeah.
next question. How do you mention the sex disorder in your report? Do you reveal the gender, right? Or is the
So in my report, it's very simple, straightforward. I mentioned that there is an abnormal bulge seen on both lateral aspects, query scrotum, query labia majora. Very simple, straightforward. Or I mentioned things like there is a hypospadias. Very straightforward. Or the fact that there is a micropenis with a unilateral undescended testis and one descended testis. Or the fact that I see a penis and I see a uterus in an inguinal hernia. So with me, it becomes very simple because I have the support of the PCP and DD department. But this does not apply to everybody else.
last question to you, sir. What happens if we miss such thing and the patient comes back to us after the birth and says that you said everything is normal, and then we show the PCP entity that is written neither detected nor disclosed? How safe are we with that statement, sir?
We're completely safe with the statement that we did mention it and didn't determine it, and we should actually take advantage of it. It's very simple.
Okay, thank you so much, sir.
I would like to add something here.
Yeah.
Even if, ultimately some case like this is going to reach a court, and there a judge is going to decide, and he may, take into account the PCP entity regulation, or he may simply decide that no, it is there in the PCP entity that you can see, you can write. So it is totally, we do not know at present. So someday we will have clarity, but for that, somebody will have to suffer.
Thank you, Alok. Thank you. So Reba Bhatt has congratulated all the young guns for the excellent cases. Thank you so much for that. And Dr. Nova Singh, she has put up a question that when ADPKD is likely to become symptomatic in adult life and does not really have immediate postnatal implication, what is the need of 4-weekly scan?
Yes, because actually, like I've mentioned, ADPKD primarily diagnosed in pregnancy is very rare, and mostly it is diagnosed as echogenic kidney in the second or third trimester. So in those cases, the differentials comes to mind, and we have to monitor the amount of liquor and the evolving anomaly of the anatomical structure of the kidney. For that, we need 4-weekly scans.
Okay, okay, fine. And I'll skip some of the questions because they're repeat. And again, when we suspect ambiguous genitalia on specific request, can or will the lab reveal genotypic sex on amniocentesis? Would you like to answer, Ishwar?
Yes, sir.
Ishwar, like when
Yes,
you
sir.
suspect ambiguous genitalia, on
Yes, sir.
specific request, can the lab reveal the genotypic sex on amniocentesis? Just to confirm that what you're seeing, the phenotypic and the genotypic, whether there is concordance or discordance based on that.
Uh,
I think boss has to answer this again.
You know, it's
Please,
the same answer again, Khurshid. The problem is that every lab is entitled to report the genotype, and that is the way it's supposed to be. Unfortunately, the labs are terrified and the labs are terrorized because they've been through it all. Even for new rules that come out, like they have to have a registered office. What sense does it make? How does a registered office going to prevent sex determination? These are unfortunately the tragedies of living in this country with a bureaucracy that is lost somewhere 100 years ago, when the purpose of bureaucracy was not to facilitate but to suppress. We have evolved as a society, but not every human being has evolved as a society. And the labs, poor things, will be in deep trouble when they're forced to shut down. There's so much of an investment in a lab, in terms of equipment, etc. And tomorrow, canceling the license means that they can't pay for the loans that they have taken. And so the labs, poor things, will always say, I cannot mention this in my report. And it's really not fair to pressurize them until we as a nation improve our everyday ethics.
Thank you
And
so much, sir.
one thing I would like to add, Khurshid, here is that
Yeah.
when we are dealing with ambiguous genitalia, actually there is no rush. You know, we
Right.
cannot make a proper diagnosis most of the times antenatally. It is always prudent to wait, deal with the emergencies like CAH. If they're not emergency cases, then it is always better to keep it, do it slowly, do a lot of testing to reach the final conclusion. Because as he showed that, there are multiple differential diagnoses which are there for DSDs. And sometimes in a rush to make a prenatal diagnosis, we may be overlooking some things which can be easily handled after birth.
You know, there is
I
Absolutely.
completely
Absolutely.
agree.
yeah, you know, there is this overriding pressure that when a child is born, the second question always asks, is the baby okay? Is it a boy or a girl? Now, this
Right.
can be quite tricky, and what we've started doing fairly many years ago is very close to term. If we find that there was an ambiguity, we would actually go in for an amniocentesis so that we save that much time in the antenatal period. So at 37 weeks, we used to do an amniocentesis. On the off chance that the patient went into labor after that amniocentesis, it didn't matter really because the baby would still be at term. But those few weeks that we require for a QFPCR and for a culture with karyotype would be covered in that much time. So that sometimes makes a lot of difference.
Absolutely right, sir. Absolutely. So we'll come. Thank you, Shruti, for your comment. And then the last questions from Dr. Rupali, that for female genitalia, other than absence of scrotum and 4 echogenic lines, anything else to be sure it's a female, Ishwar?
Sir, we'll go and
Anything
see
else
for
you want
the
to add?
rectovesical space, where we can, if the rectovesical space is increased, is point towards the presence of female genitalia, and it will help us confirm it whether it's a female or a male fetus.
Okay, okay. And can you tell me what is the learning curve to be sure of the rectovesical space? And are you seeing in all the cases of, I mean, how comfortable are you in looking at the rectovesical space each time you see?
Sir, it is very much delineable, and it is
Okay,
yes, we can see it in every
fine,
scan, sir. It matches with the diagnosis. Yes.
fine. Then Anshu Sharma has added, I wanted to share this thought because we have been studying this for almost 15 years now and documented the results and follow-up for 5 to 10 years in some cases. I need your expert opinion on this. Okay. So thank you so much for all your comments and questions. So hope we have answered most of them, and extremely sorry if I have missed any one of the questions. And with this, I would like to invite Sita to put her concluding remarks before we close the session. Thank you so much.
Thank you so much, Khurshid, and thank you to Professor, our mentor emeritus, Khurana sir, for joining in and giving your expert input, sir. I'm so proud of these young guns, as Adi and Dr. Alok Vashne said. They don't look like young guns. They are all seasoned presenters. So really proud of that. And we too have learned a lot on evaluating the kidneys and the fetus. Thank you so much. Thank you, Khurshid, for all the coordination.
Thank you so
Your
much.
final comments, sir. Khurana sir, your final.
Sir, yes, sir, your closing comments, sir.
My closing comment is on two lines. One is that our general audience seems to appreciate case studies by young people a lot more than didactic teaching, which is such a fabulous conclusion. I am just so pleased with something like this, that there's young blood and there's fresh thinking and there's great mentoring going on, and we're moving forward as a society. That is a huge achievement that we have discovered, not necessarily by chance. And I must say, a lot of credit is due here to our next generation. We had, when the concept first came up with the young guns, we were wondering whether it would work. But after looking at 330 people at most of this webinar today, it's obviously the right way to go. We have a hesitation, as everybody, young and old, to not to keep quiet a lot of the times. But when we have a younger person presenting, we seem to come forth, and we seem to communicate better with what the young people are thinking than to what the usual suspects, as I call the stalwarts, are thinking. And I think we're now hitting this correctly, that we are going to go ahead with the Young Guns program. And Varun from Pune and Alok have come up with this great idea of the Young Guns, and everybody's pushed it at various levels. It seems to work very well. What Alok has also proposed is that we have a middle level where, again, a mid-generation will present some things in their own way. And I think we're going to present a whole series on that in the near future. And that is really going to be fantastic. So the Young Guns is on one side. The second thing is that we are never going to run short of teachers, and we're going to have a perpetuation of the great values that the Society of Fetal Medicine has always wanted to achieve, which means that we will pass on the message without there being any gaps that are generational, and we will build on each other's foundations rather than being lost after a few years when few people disappear, as has happened to so many leading organizations. Thank you very much for carrying this idea forwards.
Let's do that.
Thank
Wonderful.
Thank you, sir.
Congratulations. Good night.
Good night, sir. Congratulations.
Sir,
Good
for the
night,
vision.
everyone.
Thank you very much.
Thank you. Thank you
Bye-bye.
so much.
Bye.